So next topic is pilonidal sinus. Okay, it's an interesting topic. The pilonidal disease consists of sinus situated short distance behind the nose. What that area is known as? Natal cleft, right? So extending from natal cleft up to the coccyx. So this is the area. The word is from the Latin word. The pilus is air, and the nidus is the nest. So this is the nest of the air. Pilonidal sinuses can also develop in different areas, like in axillary area, umbilicus, in barbers you can get in the web space, in the fingers. So there are other areas where you can get pilonidal sinus. But mainly we are discussing pilonidal, sacrococcygeal pilonidal is what today we are discussing. So the male incidence is very high because it is usually in the hairy person. So around 74% of the patients who come with the pilonidal sinus, they are male predominance, and the female patient is 26%. And majority black hairy person are very prone for this disease. Other area, finger webs, in barbers, axilla, perineum, umbilicus, there are other common sites. The clinical feature is basically it starts with formation of abscess. Now, how this formation of pilonidal abscess or fistula in a hairy person, the dead hair which they shed off from the back, they collect just above the natal cleft, over the hips, and while walking, these action basically causes them to go into the natal cleft, and they start burrowing that particular area, the skin, and they somehow enter into the subcutaneous tissue and they go deeper and deeper down. So this is how the pilonidal sinus formation is here. And later on, once these hair or the tract gets infected, then there is formation of pilonidal abscess, right? So many times they burst automatically, and there is a discharge of pus, patient gets relieved, later on patient comes with a discharging sinus, then you come to the surgical OPD, diagnosis is pilonidal sinus. Many times that doesn't automatically burst, you have to do incision and drainage, curatives, but most of these pilonidal abscesses, they don't get well after incision and drainage, the recurrence rate is very high and they immediately come with the pilonidal sinus. Now understand the difference between sinus and fistula, because here there is a blind end, and in fistula and inner there were two ends. So this is the difference. The sinus is different and the fistula is different. This is the sinus, this is a pilonidal sinus. So recurrent abscess formation is there. Recurrent abscesses they lead to the again and again. So there is burst of another area. So many times when the chronicity of the disease is there are multiple fistula openings you can find in the pilonidal sinuses. But they are all together connected to each other. This is how the pilonidal abscess looks like. This is the bulging, the redness, and the inflammation is there. This is how the hair is getting out of the sinus. You can see this is the tract. And these sinuses, remember, they are always in midline. They are in midline. You have a secondary tract laterally also, either side. But the basic, the primary tract is always in the midline. These are the multiple openings, but they are like all in midline. Can you see? And these are the bunch of hair. When you cut open the sinus after the excision, you will find all dead hair. This is one thing which is very important. There is no living root of hair is there. All dead hair you will find into the sinus tract or in abscesses. The examination is sinus post-anal region in the vertical cleft extending up to the sacral area, up to the coccyx it may extend. This is accurately in the midline, so when you do surgery, this thing you should remember, whatever repair you do, it should be away from the midline so the recurrence is very low. There may be single or multiple openings, but the edges are smooth and the hair can be seen in the opening. The treatment of pilonidal sinus, basically if the inflammation is there, give a broad spectrum antibiotics, incident drainage of the abscess, curettage of hair and granulation tissue should be done. We should try to treat properly so that the recurrence should not be there. If you have done a good incident drainage and curettage of the pilonidal abscess, many times you may not get formation of pilonidal sinus. Now, if the chronic pilonidal sinus is there, what is the option for treatment, surgical treatment? Initially, when there was a lot of debate over the primary closure, then they used to do the laying over or marsupialization of the sinus. But the recurrence rate is very high. They usually don't get all right. Primary closure, you excise the whole of the sinus tract in doing a primary closure. In double layer primary closure is done. But this is for a small pilonidal sinus, you can get a good result. But if the multiple pilonidal sinuses are there and the chronicity is there, then the primary closure doesn't work. Secondly, if you do a primary closure when the patient go for defecation and squatting position, the sutures usually get tension and they are disrupted. So the primary closure doesn't work and there is a wound dehiscence. So primary closure usually doesn't work. If a small sinus is there, then okay, you can do that. Then Z-plasty, Caridakis procedure, limber flap and vascom. I think limber flap you have seen. Vascom I did few days before back. The patient did very well. Caridakis flap and vascom flap are more or less similar kind of procedures. The Z-plasty, simple Z-plasty is that you can see that this is a kind of a Z. Excise the tract and do a simple Z-plasty. This for small pilonidal sinus Z-plasty is a good procedure if you do that. This is Caridakis flap where you go laterally and take out the sinus laterally and close the wound. Before closing the wound, the subcutaneous fat should be dissected out and it should be covered to the area where you have done the excision of the tract with the side incision. So that the first layer fat should be there and then you stitch the skin. But it should be away from the midline that you should take. Because you see, the incision is electrically taken. Up to this particular area. So this is going to be here, it is not covering the midline. So the suture line should be away from the midline. This is the limber flap, it is a rhomboid flap. This is far better here because this is a kind of a rotational flap. What you are doing a rotational flap surgery. Here you excise a rhomboid, you can measure it, it should be 120 degree angle here, and you take this length and make it exactly similar length over here, right? Because this portion is going to be attached. So this line and this line should be similar. You make a 120 degree angle, here you get 60 degree angle. And it should be away from the midline. This portion should be away from the midline. This you always do. And then you excise the whole pilonidal sinus from its base. Basically, doing pilonidal excision spills some kind of vigilant fluid into the tract, so that the whole tract of the sinus gets blue colored. While doing excision, if you find that there is any kind of a leakage of the vigilant fluid, then you should be careful and it should go a little deeper, so that you should excise the whole pilonidal sinus. There should not be any tissue of pilonidal should be left behind, because they may cause recurrence of the disease. So the vigilant fluid you should inject it a little bit into the sinus, it gets fluid, then you excise the pilonidal sinus up to the base, up to the post-sacral fascia, and then do a good hemostasis, and then take an advancement flag, rotation flag. This should be taken from this area, and it should be deep up to the gluteus maximus muscle fascia. That deep it should be. Then only the vascularity of the flag will be there. So these things you should remember, because now you will be becoming postgraduate student, now becoming surgeons now. So you should remember all basic understanding, that when you do in your practice, you should remember all these points. And then suture. This is Bascom's strap. Similarly, you do it. I'll show you some video some other day. I've got a very good video for that. And you can perform it. Because this is also for a simple pilonidal sinus, not a complex pilonidal sinus. Because the simple pilonidal sinus, with this procedure, the patient has got less compliance as compared to the liver flap. And it's a small procedure for a small disease. Right? What are the causes of recurrence of the pilonidal? If the incomplete excision is there, if you have left some part of the sinus, then the recurrence will be there. Then you can have a new hair entering into the skin and into the scar area. That is why you want that the scar should be away from the midline. So it should not collect there. Because scar area is prone to get punctured easily as compared to the normal skin. So you can have, if the midline scar is there, then the recurrence will be there. Persistence of the wound caused by the breaking of scar. If the scar is under tension, the breaking would be there, and then again the hair will enter into that, and then the recurrence of the pilonidal sinus will be there. This is all.